Good afternoon, everyone. Welcome to another COVID-19 webinar series hosted by Botswana-Rutgers Partnership, as well as University of Botswana and Botswana-Harvard Institute Partnership. We continue with our webinar series from Monday, and today's topic will be on fundamentals of fluid assessment and fluid management, and in the management of critically ill patients with COVID-19. As usual, I'm going to go through our house rules before we begin. This webinar series are co-organized by Ministry of Health, University of Botswana, Botswana-Harvard Partnership, and Rutgers University. You can join the mailing list by emailing Robert Mumakwa at rmumakwa@yahoo.com, and Robert will invite you. The sessions are over Zoom. We had a pause over the Christmas break, but we restarted them this Monday as the pandemic here starts to peak. Please, during the sessions, so that the presenter is audible and we don't get any echo, can you mute your microphone until at the end when we invite people to actually comment and ask questions. You can ask questions actually using the chat functions, and what the moderators will do, they will monitor the questions, they'll respond, or we will wait and respond after the presenter is done. These webinars are recorded and made available after the session, and both the recording and the slides will be shared. And we are happy to take feedback sessions so that we can make these webinars actually better, and so that you can have a better experience. So what we want to do today actually is we are going to run a question poll, a 4-question poll towards the end. This will be anonymous, and we're going to invite participants to actually answer questions. And this will allow us actually to know exactly what participants are interested in and how these sessions can be improved for the future. So the webinars actually are on YouTube via the Botswana-Rutgers Partnership for Health. As you can see down there, these are the previous webinars that we've had. I encourage people, if you haven't gone through these webinar series, they actually go through the clinical management, epidemiology, case definitions, COVID updates, and it will be good to just to get yourself up to speed. On that above website, covid19portal.gov.bw, you have an option to go there and have access to different access points, from information about interzonal permits, to the zonal map, to the data dashboard, including the document library. Actually, under the document library, you have all sorts of guidelines. I usually get a lot of calls on people asking me to send them COVID-19 clinical management guidelines, isolation facility guidelines. These are all here, and they are usually updated, obviously, as new information comes in, as we've seen that there's a new viral strain. Okay, let's move on to the session. Today's session on fluid management will be conducted by Dr. Alexei. Dr. Alexei is a physician and intensivist. He graduated in Cuba in 1995, and he immediately went into internal medicine training and graduated as a physician in 1998. From there, he trained as a critical care physician or intensivist. And we are lucky to have him because he does have actual experience in managing the pandemic. He managed the H1, he was involved in managing the H1N1 flu pandemic while in Cuba. He's currently under Sekit Tumila Masira and has been vital in not only teaching, but leading the response in the ICU here at Sekit Tumila Masira. So he's a perfect person actually to talk about fluid management in critically ill COVID-19 patients. And without further ado, Please let me welcome Dr. Alexei.
Okay, thank you. Afternoon for everyone. Okay, as Dr. Palai has said, we are going to touch on fundamental fluid assessment and management in critical ill COVID-19 patients. That is a very important topic in this pandemic. Okay. The objective of this topic, of this talk, is a recognition of fluid deficit and fluid overload in critical COVID-19 patients, appropriateness of use of IV fluid administration, type and quantity, and awareness of the potential complication of PPV, is mean positive pressure ventilation, on fluid administration in COVID-19 associated LDS. Topic outline of this lecture is brief introduction to understand the basics, assessment of fluid volume status intravascularly and extravascularly, fluid management itself, and in this regard we are going to touch in three aspects, mainly the type of intravenous fluids, phases of fluid administration, fluid replacement, and effect of positive pressure ventilation on fluid management. I'm going to start with this slide that was the last slide presented by the previous presenter in the webinar, because introduce this oxygen delivered to the tissue that is not only a function of the oxygenation, it means how able the lungs are able to oxygenate the blood, because that blood needs to be taken to the tissue, and that is function of the cardiac output. That's why IV intravenous fluid is very important, because as you see, cardiac output is depend of the stroke volume and time heart rate. And the stroke volume at the same time is determined by venous return and heart contractility, and the venous return is determined by intravascular volume. It means if you have low intravascular volume, you will have low cardiac output, and therefore you will have low oxygen delivered to the tissue. That is the final destination of the oxygen to be used by the tissues. In this basic thing that all of us know about physiology, there are two main compartments where the fluids and electrolytes are distributed, mainly the intracellular fluid and extracellular fluid. If you remember, intracellular fluid accounts for 40% of the body weight, while the extracellular fluid accounts for 20% of the fluid. And extracellular fluid is divided in interstitial fluid and intravascular. Okay? And if you see among those compartments, there is a free fluid movement between them, and that is very important, because if you see intravascular, there can be move of fluid into the lung, into the intestine, into the skin, and kidney, of course. And that is happening because in RDS, if we have, we will see later, if we expand the intravascular volume, then we produce impaired oxygenation, because we are flooding the lung with fluids. And if we then dry the patient, then that oxygen is not going to get properly to the tissue, because we are compromising the oxygen delivered to the tissue. That's why we need to be accurate how we manage our fluid. Then, first of all, we need to know how we can clinically, and using some adjunct, we can determine the volume status of the patient, intravascularly and extravascularly. There is a clinical and some adjuncts that we can use to determine those volume status. Intravascular volume you can assess clinically through the mental status, UR venous pressure, the BP and its postural change, urine output, and capillary refill test. And adjuncts, we can use the CVP, the central venous pressure, mainly is using ICU and HDU. We can use perfusion index, we will see later, and serum lactate and point of care ultrasound, assessing the inferior vena cava diameter. And then extravascular volume can be assessed clinically through the skin target, mucous membrane dryness, peripheral edema, and we look at the eyeballs. Adjunct, this is very advanced technique that in ICU can be done, but we are not going to touch in this because it's very advanced thing. Jugular venous pressure is very easy to determine. Sometimes people think that we need to insert a central line to measure the pressure in the venous system. Really, if you want to remember that the superior vena cava, when it reaches the atrium, there is no valve, and the contraction of the auricular can produce a backflow that is a jugular pulse, that you can determine the highest of that using a normal rule over the angle of the sternum, and then use a draw a horizontal line where you see that pulsation. And normally is less than 4 centimeters of water if you're taking as reference or landmark the sternal angle. If you use the center of the right atrium, normally that is located 5 centimeters below the sternal angle, and that's why you have to add by 5, you have to add the measurement that you do about the angle of the sternum, and that will be, in that case, less than 9 centimeters. It's very important, the BP, of course. When you assess intravascular volume, remember that blood pressure is a product of cardiac output and vascular resistance. And if you have low cardiac output, you will have change, or high cardiac output, you will have a variation of the BP. That's why intravascular hypovolemia can be suggested if there is 2 conditions. It means you see that there is a postural change. It means when you change the patient from supine to upright position and the BP drops, that is evidence or suggestion that the patient is hypovolemic. As well, if the patient is lie down and you raise the legs and the BP improve, normally systolic BP by 10% of the baseline, you can say that this patient, is hypovolemic. Other important parameter clinically is the urine output. Okay, good urine output is good is more than 0.5 ml per kg per hour, reflect adequate organ perfusion. Okay, the opposite is also true. It means poor urine output reflect poor organ perfusion. Capillary refill test and perfusion index is mean as a physician and clinician, we know how to do it. Normally when it's prolonged, it means prolonged is more than 3 seconds in younger adult, and in elderly more than 4.5 seconds. That indicate poor peripheral perfusion. And there is no well-defined cutoff value for perfusion index. We will see later on. Then for those ones, it means that maybe it's to remind about how to do or perform the capillary refill test. Normally you press over the finger and you see until it you blanch the finger, and then you release. And then you take the time that is taken to refill, and that time is the one that you say that is prolonged or not. Okay, we already said about those parameters before. And then the next the perfusion index, that is a short screen for one of our monitor, and if you see in the right part in the bottom, in the saturation, you see the value. You have 3 values. The first value is the saturation itself, but then you will have the other value at the right on top. That is the pulse according the pulse oximeter, and the other is the PI. That those monitor we have been used here in second to minimum series, and this PI is perfusion index. That there is no clear value. Normal, some reference say that is 0.3 to 10, but the most some others say that below 5 is low, or 5 is high. But the most important is to check the trend. Okay, if you see that the patient is trending up, it means you are regaining perfusion. Right? The other is as well. If you see that it's dropping, it means that the perfusion is deteriorated. Okay. Then how to assess the extravascular fluid volume? Made by mucous membrane assessment, the eyeball and decrease and the skin target. If you have dry mucous membrane, it means that important. If you see in the first picture A, there is a patient that is in respiratory distress. They most of the time they try to open the mouth to breathe through the mouth, and then that's why you can't assess the tongue, the upper part, as a sign of dehydration, because will be dry because the air that the patient is inhaled through the mouth. That's why you need to look under the tongue, like the second picture that is wrong label as E, is the B, is E but the correct one. You need to assess under the tongue, even internal part, inner part of the lips, of the lower lips, okay? Don't assess the tongue, the dryness of the tongue. Then the other picture, you show the sunken eyes when the patient is fluid depleted. And then the last one is how to assess the skin target, okay? If you see, you pinch over the skin in the clavicle, and then you release, and if the skin return back to normal, there is no skin fall, but if there is a skin fall, it means that the extravascular fluid is contracted. Summarizing those findings of intravascular, how to assess intravascular and extravascular volume status, we will see that for contraction, we will see that the mental status will be depressed, and GVP will be collapsed. BP will be normal, or will be orthostatic hypotension. Remember that we said before that when there is a orthostatic change of the BP, that is indication of intravascular fluid contraction. If the urine output is low, is indicator of poor organ perfusion. It means the intravascular volume is low. As well as there is a prolonged capillary refill test is prolonged, as well as other indicator of intravascular fluid contraction. Using adjunct, we will see that the CDP will be low, the perfusion index will be low, the serum lactate, that is indicator as well of tissue perfusion, will be low. Here is very high, it's low, it's not high, sorry for that. Intravascular fluid contraction will be low. It's correct, sorry, it's high. The serum lactate is high because that is anaerobic metabolism, okay? That's why we lead to high serum lactate. And IBC diameter will be reduced, okay? That is most of the time done for need some kind of expertise or skill in doing that. That must be at your setting. Is not possible, or you can get the assistance for a sonographer is accessible. In our setting, sometimes we get assistance from emergency physicians that are skilled in doing that. Meanwhile, intravascular fluid expansion, mental status, the patient will be agitated, GVP will be decreased, it means distended, and BP will be normal or high because the intravascular volume is high. That's why, remember, cardiac output is one of the determinants of the BP. That's why cardiac output high, then you can find the patient is hypertensive. That sometimes is not well interpret as a fluid overload, that hypertension. urine output is increased, it means you can have a patient polyuric, okay, because intravascular volume is expanded and then patient is polyuric. And the capillary refill time is normal because there is no problem with the perfusion. The patient is hypoperfusing. The CVP, of course, using adjunct is high, the perfusion index will be high, and serum lactate in this case is normal because the perfusion is normal. There is no impaired perfusion. And the IVC, because the intravascular volume is expanding, will be increased. The diameter will be increased. Then, regarding then extravascular volume state, that when the extravascular volume is contracted, or there is a contraction of the intravascular volume, there will be a positive skin fold. It means the skin fold will be there. Peripherically, we won't find edema. It means edema is absent. You will find dry mucous membrane and sunken eyes. And with adjunct, we were not going to talk because it's very high advanced technique. Extravascular volume expansion, you will see that the skin fold is negative, okay, because the interstitial space is well filled, even is overexpanded, and no edema. Sorry, edema because there is edema because the extravascular volume is increased. That's why edema is present. And excessive lacrimation and chemosis is very common. Then let's talk about fluid management. First of all, type of intravenous fluid. When you are using fluid, in the first slide, with the second slide that I present, there was a composition of the intracellular and extracellular fluids. That is the one that we are trying to mainly the extracellular fluid, mainly the intravascular is the one that initially, despite there is a free movement of water between compartments, and this one you can influence extracellular fluid, giving even the fluid intravascular. That's why if you those type of can be classified mainly in three types: water-based solution, that is D5, the dectro 5%. That this is no suitable solution for resuscitation. Never use D5 to resuscitate a patient. At least that you are in a remote area, you don't have any other things, okay? But it's not ideally a fluid to use in resuscitation, mainly because the glucose is going to be metabolized by the liver and only is going to remain water in the intravascular fluid. And then that water is going to move freely extravascularly and is not going to replete or replenish the intravascular space. That is the one that when you are resuscitating a patient, you need to fill. Then crystalloid solution, that is some kind of electrolyte-based solution that can be divided in isotonic solution, hypertonic solution, or hypertonic or hypotonic solution, depend of the relationship between or the relation with the sodium concentration to the plasma. And the most crystalloid solution, the most widely used crystalloid solution we have is saline 0.9%, we call Ronley normal saline, and Ringer's lactate. Those are the main two fluids that we use in resuscitation. The other fluid is hypertonic solution. We don't have it in our setting, and it's not recommended only in trauma setting. And hypotonic solution we only use when the patient is hypernatremic, that we want to provide a free fluid water. Then we have the third one, that is colloid, that is a macromolecule. It means large molecule that stay for long intravascularly, and then pull or draw fluid intravascularly from the intertissue, intracellular. Among those, we have albumin, that is the most common and widely used, that is only used in resuscitation when there is a coexistence of hypoalbuminemia. That is the only situation where you use because even it's more expensive, and research conducted in that regard hasn't proved any benefit with crystalloid. We have as well gelatin that is available in our setting, like we call gelofuscin, and is only used when a less large fluid volume administration is advisable because certain other conditions. And star and Dectran that we don't have in our setting, but it's not recommended, and it has been abandoned because side effect, mainly kidney and some coagulation disorders. Then regarding phase of fluid therapy, we have 4 phases. As you see, the first phase is rescue. Rescue or resuscitation phase is when your patient is very hypotensive, means very, we call it hemodynamic unstable with very low BP, and patient is hypoperfusion. In that phase, we will see later on how we address. The next phase is optimization. It means you manage to rescue your patient. Now you have to use wisely your fluids, because remember that we are facing LDS, and you don't want to fluid overload those patients because you are going to flood in the lung with more water, and then you are going to impair oxygenation. You are going to get worse the lung compliance, and then you will require more oxygen from the vein. You will require more pressure from the vein, and will be a problem. That's why we will see how we manage that phase. Then stabilization phase and de-escalation. Rescue phase of resuscitation. Here we said that the patient is very unstable hemodynamically, hypotensive, oliguric, high lactate, and then in that phase you have to restore the intravascular volume quickly. That's why you have to administer around 250 to 500 ml of renal lactate or normal saline over 15 to 30 minutes. This means we call IV bolus or IV challenge. And then you repeat this amount until you get your target, clinical target, or until you reach a maximum of 30 ml of per kg, around 2 liters within 3 hours of the administration. Then the clinical target that you have to monitor to ensure that you have reached your target are, of course, is similar to what we have assessed before, good mental status, systolic BP more than or equal than 90 millimeters mercury, or a MAP more than or equal than 65. Normal capillary refill test and perfusion index. Remember that perfusion index is a trending issue, like BP as well. It means, but mainly perfusion index, because there is no clear cutoff value. You need to assess the trending up or trending down. If improving, of course, should be a trending up. The urine output more than 0.5 ml per kg per hour. The CVP in the setting that is possible to measure, with the 8 to 12 millimeters mercury for non-ventilated patients, and 12 to 15 millimeters mercury for ventilated patients. That is because when you apply positive pressure, that pressure is going to be transmitted to the right atrium, and then the pressure will increase. That's why in ventilated patients, the CVP value is higher. Then the serum lactate less than 4 millimoles per liter, and as well you have to check the lactate clearance. That is other parameter more than a absolute value. You take the rate of clearance that need to be more than 10-20% of the baseline. Then the IVC that should be within normal diameter. The normal is 1.2 to 1.7 centimeters. Then in the optimization phase, it means you manage to rescue your patient. Now you have to move wisely with your fluid. How you do it? Initially, you have to set a daily requirement for fluid that normally oscillate between 30 to 40 ml per kg per day. Normally, to have a clear and avoid memorize too much number, you can use 30 ml per kg per day the first day. And then you have to add your electrolyte. That is very important, because normally we use normal saline or renal lactate that has high enough content of sodium and water, but normal saline doesn't have potassium. That's why we, in that regard, we need to add potassium, ensure that the renal function and potassium, plasma potassium is normal. Then in that phase, you have to monitor closely the urine output, the ongoing losses, is mean nasogastric tube aspiration if the patient has in situ a nasogastric tube, or vomiting if not, diarrhea, drains, or other losses, plus insensitive losses, mainly in non-ventilated patients. And then you need to match that, that volume that you have recorded, you have to match and administer with a crystalloid solution. I say always analogy, I use analogy. If you have a container of 1 liter and you have a tap and you open the tap and you empty 500 ml, you need, and you close the tap and you need to fill that container with 500 ml in order to make the baseline volume of 1 liter. The same happens in the body. In that case, the tap will be the kidney, but the human body has other taps that is through the lung, through the gut, that you move bowels, you eliminate fluid through the respiration, and that amount of fluid that you are losing or the patient is losing need to be accounted for as well, and then we need to replace. And sometimes in this phase, sometimes we need to conduct some tests to assess fluid responsiveness. That means if the patient warrant further IV boluses. And the most common use is passive leg raising. Basically, the passive leg raising, if you see in the figure, you need to put the patient 45 degree chest up initially for 1 minute, and then you have to turn down the chest and then raise the leg for 1 minute more, and then ideally you need to monitor cardiac output. Is the auxiliary parameter that you assess. But if you don't have arterial line with availability to monitor cardiac output, you can monitor the systolic BP, and if there is increment of the systolic BP of or more than 10%, that is mean that the patient warrant extra fluid. It means extra bolus of fluid. Those 250 or 500 ml that I spoke earlier. That is when we give a bolus. If no, it means the patient shouldn't be give fluid because it's not going to increase the cardiac output. That is the baseline. Then regarding estimation of insensible losses, those patients that come on respiratory distress, they are tachypneic. And remember that through the lungs, you are losing those patients that are tachypneic, they are losing fluid that you are unable to see. That's why insensible. But you need to account for that. That's why all patients that come tachypneic, you have to put a cannula, we will see later, and give fluid. And this is the way how you calculate. It means we apply the rule of 8. It means after the 20 breaths per minute, that is the limit of normality for adult, you add 8. It means 20 to 28 will be 0.2 ml per kg per hour. 28 up to 33, the patient will lose 0.3 ml per kg per hour. 36 to 24 will be 0.4 ml per kg per hour, and more than 44 breaths per minute, a patient is losing 0.5 ml per kg per hour. As well, if your patient is spiking fever in a period of 24 hours, you have to add 150 ml per each degree Celsius, about 37. That temperature is the average in 24 hours. Then the importance of fluid balance. Fluid balance is very important when you are setting your fluids. And ideally, a scenario in ideal scenario, you will see that in this figure, you have intake and output that the total for both is the same. It means 2,400 mil for each. It means the ideal balance is 0. It means the same amount that goes in should be the same amount that exceeds the body. But this is an ideal that most of the time is not achieved. There is a permissive that we will see. To do that, you have to quantify intake and output, including insensitive losses in those patients that are not on mechanical ventilation. Okay, insensitive losses we see earlier in the previous slide how to estimate. Then once you have your intake and your output, you do a balance, like a balance of anything. And then will be negative if the output is more than the intake by 10%. Will be positive if the intake is more than output by 10%. And will be neutral or steady state fluid balance if the intake is and output is between 10%. And then you calculate the cumulative fluid balance. That is very important as well, because as we will see later on, we will see that in example, that importance of cumulative balance. But normally you calculate by the current balance is being the current balance plus the previous balance, and then that will make your cumulative balance. And you targeting a negative fluid balance without compromising tissue perfusion. If you see in this example, that is a scan of one of our chart. Here in this cell, we record all input, everything that goes into the patient, and then it's added until you get, in this cell, you get the total input. And in this case, it's 946. And then in that other part, you record all that exceed the patient, okay? In this case, only was urine, and that was 1,410. And then you will have a negative balance, in this case, of minus 463.6. And then this amount you add to the previous one, okay? The previous one was here, this one minus 2,688, plus the current one, that is this one, will give you, a negative balance of 3,152.2. It means almost 3 liters, more than 3 liters of negative balance. That is mean that is why if the perfusion is not compromised, that is good, because we are keeping the patient dry. Then the other extreme, fluid overload. Fluid overload as well is very bad as well for a patient RDS, because if you see among the consequence of fluid overload is pulmonary edema. And remember that RDS is non-cardiogenic pulmonary edema. It means if we are producing more edema, we are impairing more the gas exchange, we are reducing lung compliance, and that's why we need to use higher IFO2, higher pressure for the ventilator to inflate the lungs. That's why we have to be, that's why the importance of fluid balance to avoid that. Normally fluid balance in ICU setting, we diagnose by increasing the weight by more than 10%. But that's only in ICU setting that ICU beds are able to weight our patients. For out of ICU, you have to do clinically, because through the clinical parameter and adjunct that I spoke earlier. Then stabilization phase. When you have reached that phase, you have to see and move wisely, and make and have a look if your patient has any evidence of poor tolerance to IV fluid. And those are the conditions that you have to be aware that the patient tolerance to IV fluid is no good, like heart failure, cardiac disease, renal disease, dilutional hyponatremia, edema, or ascites. Then in this phase is when the transition to oral fluid happen, including diet and diet. Then de-escalation phase. de-escalation phase is very, it's other phase, the last phase. It means once you reach the stabilization phase, one question needs to be answered. That question is this patient still require IV fluid? You have every day you need to raise that question to you. If the answer is no, then you stop IV fluid straightforward. If the answer is yes for any condition, then you need to consider cutting in that IV fluid, or even move to oral, increase the fluid orally. Then the now important topic, because we have to, most of those patients we put on positive pressure ventilation, even non-invasive ventilation or via invasive ventilation. And that can affect the positive pressure ventilation, affect all phases of the fluid therapy. In the rescue phase, the BP can drop dramatically when positive pressure ventilation is applied in hypovolemic patient. That is very important, and we will see why. If in this diagram you see in spontaneous breath, you have that when chest cage expand because the diaphragm contract, the diaphragm go down, okay, and then the intrapleural pressure drops. That causes the intrapleural pressure is the surrogate of intrathoracic pressure, and then the intrathoracic pressure drop while the intra-abdominal pressure increase because the diaphragm goes down, and then squeeze the diaphragm squeeze the intra-abdominal pressure, increasing the pressure, and then there is a gradient. Remember that in physiology, the blood flow moves from across pressure gradient, and then if you have higher gradient here and lower gradient in the chest because the chest drop, then the venous return increase, and that's why the cardiac output increase, and then the oxygen delivery to the tissue increase. But it is the opposite when you apply positive pressure ventilation. When you apply positive pressure ventilation, you are generating, or the ventilator is generating positive pressure within the patient's chest. It means the intrathoracic pressure increase, and if you see positive, all pressure in the cavity are positive. That's why if you are hypovolemic, you are delivered here, the mean systemic pressure is low. It probably sometimes subatmospheric. That will sometimes collapse. And then if you apply positive here, and here is drop the pressure distally in the periphery drop, then the BP is going down, the venous return is going down, the cardiac output goes down, and then the BP goes down, and then oxygen delivery compromised. And sometimes you will find by experience that immediately after intubation, the patient crashes and sometimes go to cardiac arrest. And that is because of that issue. That's why before you apply positive pressure ventilation in hypovolemic patient, you need to resuscitate the patient. And make sure that the shock index, that is a very simple parameter to measure, that is the heart rate divided by systolic BP, is more than 0.9. If it's less than that, you need to complete first the resuscitation phase, and if it's more than that, you have to complete the resuscitation phase before initiate positive pressure ventilation. Then the positive pressure ventilation affect as well the all other phases, mainly because it means positive pressure ventilation reduce or drop the venous return at that situation, activate two mechanisms. Remember that the cardiovascular system has a sensor, a volume sensor and pressure sensor that is sensing what happened with volume and with pressure throughout the circulatory system. And in the right atrium, there is a sensor that is the one that senses what is happening with intravascular volume. And that's why when you have a heart failure, that the right atrium distend and then release the natriuretic artery peptide. And that's why in heart failure you will see that BNP is high. But when there is hypovolemia, then that mechanism is inhibited because there is no volume. It means it's not going to release natriuretic active peptide. That's why in ventilated patients, there is a tendency of fluid retention. Because these mechanisms are because as well, the cardiac output drops. And then remember as well that in the arterial sector, there is a baroreceptor that when sensing those change in pressure is going to activate the sympathetic activity that is going or lead to the activation of the renin-angiotensin system that is going to retain more water. That's why we see in ICU your patient when it's stay for long, they are edematous because of those mechanisms. The last slide, I would like to highlight as a taking home message that all patients with severe COVID-19 have a fluid deficit due to an increase in insensitive losses. It means because of the tachypnea, which need to be corrected. It means you need to put on IV cannula or cannulas and monitor urine output, ongoing losses, insensitive losses, and then you have to match those losses with IV fluid, crystalloid mainly. Before initiation on PPV, via non-invasive or even invasive, in a patient with a severe COVID-19, ensure that the patient is fully or in advanced way of fluid resuscitation, and make sure that the shock index is less than 0.9 before you apply PPV. Fluid overload can carry out deleterious consequence in COVID-19 associated RDS that impair oxygenation, requiring high oxygen or even level of PEEP, and poor outcomes.
Thank you very much, Dr. Alexei, for that informative talk on fluid management. I think it was quite a lot, but I think the main points were shared in terms of fluid choice, in terms of resuscitation, the importance of maintaining ins and outs. I think at this point, we will take questions from the audience, whether on the chat box. We will respond to those, but we must be aware that we are behind time already. The next point is, please do not forget that there will be a poll towards the end of the presentation where four questions will be asked, and we would appreciate your input, as this will help us direct ourselves in terms of bettering this webinar series to better suit you. So happy to take questions from the audience. Anything in the chat box? Let's see. I think for me, the most difficult thing, especially in the districts, would be monitoring of a fluid responsiveness after bolusing, or daily assessment of probably fluid balance. And even though we don't have access to those, I think Dr. Alexei touched on a couple of procedures that we can do to okay, I see something on the chat box. Someone asked, Botswana's current regimen, COVID-19, from ambulatory asymptomatic to severe clinically compromised patient. I'm assuming this is guidelines. If there are clinical guidelines, these are on the COVID-19 portal. I can share that we are currently reviewing our current guidelines from a management point of view in terms of incorporating newer treatments that have been FDA approved as of November, and a couple that are in discussion. Obviously, we're getting a lot of deaths in ICU. So things like monoclonal antibodies, we are looking into that and procuring those for severe critically ill patients in the ICU. We are developing guidelines for that for specific patients. Other drugs that are of question is colchicine. We are reviewing that as well. But obviously these drugs will have to be, the guidelines, once the guidelines are out, you'll have to discuss with an ICU consultant like Dr. Alexei, if, for example, you're transferring a patient from the periphery to here. But we expect that there will be procured first in sequitur to be used here so that we observe what results we get with those. So those will be reviewed and they'll be shared on the COVID-19 portal screen that I shared at the beginning. Anything else, Dr. G?
Thank you. It's either know it all or we are shocked because we are not getting any questions. But maybe just to the audience, we would.
There's two questions to unmute, Dr. Gaolathe. There's two participants with their hands raised to unmute.
Okay.
Go ahead, you can unmute and ask your question.
Okay, can everybody hear me?
Evening, I'm Dr. Zie. I have a question.
Go ahead, Dr. Zie.
Yes, thank you. The presentation was well organized, and thank you very much for the presentation. My question, Dr. Alexei was talking about making sure that the patient has have adequate perfusion, or the perfusion index is good before you can intubate the patients. But how do you balance that out for patients who are actually crashing in front of you in emergency when you see these patients? You know, how long do you hold off before you can intubate these patients?
Yeah.
Thank you.
At least that the patient in pre-arrest situation, that most of the time is not the thing. You remember that the fluid you push, even the faster that you can give is over 15 minutes, okay? You can push even 500 ml over 15 minutes. And because I don't know if you have experienced that immediately, I think we have some patients, several patients, that when you intubate a patient that is hypovolemic, the patient crash immediately. And some of them go into cardiac arrest. And that is because I explained earlier on, okay? And that, of course, is based on clinical judgment. You need to have the patient in front of you, make a decision, but you have to think that if the patient can wait some minutes, even 30 minutes, and give at least 1 liter of fluid, okay? Because remember that it's 500 ml over 30 minutes, over 15 minutes. Even that in 30 minutes, you can give 1 liter at least, because if you proceed to the intubation, you can find you in a trouble. That is a situation that is, you need to assess patient by patient, okay? Sometimes medicine need to be adjusted according to patient assessment and situation, but that is even the literature said, and by experience, we have found several patients that without good, and even when you see those patients, there was no, the patient can wait a little bit to be intubated. It means there is no emergency rush because the patient is not in pre-arrest situation, and there is some time to give some fluid before proceed to intubation.
Thank you.
Can I ask?
Yes, go ahead. Go ahead. I was actually about to say next participant.
Hello, everybody. Name is Poloso. I just wanted to ask, because I was worried maybe you might be having like a budget issue, but I hear that we're already procuring monoclonal therapies for COVID patients. So meaning that budget is not really an issue. On that note, I wanted to ask, why did the presenter choose as a way of assessing fluid status, the lactate, CVP? I'm okay with urine output, because I was wondering why not choose modalities that have been proven to go in line with the dynamic hemodynamic monitoring instead of the static, because we do know that CVP just shows you what the right atrium is doing, irregardless of the fluid dynamics that changes within the patient. Patient might be having a tension pneumo, tamponade, or valvular heart disease. It will fluctuate all over the place, but not necessarily tell you what's actually happening in the intravascular compartment. And also, I was a bit worried in terms of what are we saying for the people that are in the outskirts in the district hospital if we're just going to say that COVID patients need IV fluid if the shock index is more than 0.9, because we do know that a lot of them do die acutely because of acute right heart failure or PEs. If you give a lot of fluid to these patients, they won't do as good as well. So I was asking in terms of equipment, why not we go for the things that have been shown to work? CVP hasn't shown to be working. Serum lactate, if you trend it, if you look at the Andromeda shock trial, it shows that your patient will actually do worse as opposed to doing capillary refill time and stuff like that. And then in terms of hemodynamics, the fancy equipment that's there in the ICU, or like, why not go for those things?
Okay. The first question. First of all, this lecture was targeted to non-ICU people. Okay, and if you see the CVP is not a good parameter to assess fluid responsiveness. Okay, but still good parameter to assess intravascular volume. That is the how I if you see, I didn't say that the CVP is a good parameter to assess fluid responsiveness. And yes, I deal with a dynamic test that predict fluid responsiveness. That is passive leg raising. This passive leg raising, if you I touched in my slide, is a dynamic test to predict fluid responsiveness. Of course, remember that we are targeting non-ICU audience, and we can say that we can, even in our setting, we do pulse pressure variation. We do pulse pressure variation with some limitation, because if you the pulse pressure variation is no good when the target volume is less than 8. That's why we have to do some kind of delta or BT challenge to assess that parameter, because those patients require low tidal volume. But we do pulse pressure variation in our ICU to assess fluid responsiveness, and then we use for passive leg raising. There is the most widely used because it's simplest. You need to monitor cardiac output continuously. That in our setting at the moment we don't monitor cardiac output, but you can take as a surrogate of the cardiac output the CO2 is mean variation cardiac CO2 that we do measure here, as well you take a threshold of 10% of the baseline increment after the passive leg raising is conducted. Yes, of course we do those dynamic predictors, but in an ICU setting, not out of the ICU. That's why I touched on passive leg raising, that is easier to perform for non-ICU people?
Thank you for that question. Just to add on as well, I think you've raised important points in terms of monitoring fluid responsiveness. I do agree with you that for critically ill patients in the ICU, as Dr. Alexei yourself said, we have changed from static measurements like CVP, measuring the JVP and things like that, to more dynamic measures like changing pulse pressure, left ventricular outflow, as well as the caliber of the superior vena cava and the inferior vena cava. These will tell you more about fluid responsiveness. But like Dr. Alexei said, at the presentation, you have to think about people that are in the peripheries. When patients are being referred, we always have to plan. And sometimes when you give too much fluid or there's fluid overload, by the time when the patient gets here, we have to try to get them off. It becomes more difficult to wean them off the mechanical ventilator eventually. Their lungs become so wet that the ventilation perfusion ratio becomes difficult to manage initially while they're in ICU. But things are noted. From a budget point of view, I think we have to realize that Circuit Tumile, makes this decision based on management of how the pandemic is evolving. And there is, I know, as Dr. Gaolathe has been involved, there is efforts to conduct our training or setting up of sort of critical care units in the northern part of the country, Francistown. It's ongoing. It hasn't been finalized. Any more questions? I think on the chat box, the link for doing the questions from the 4-question poll has been shared. We would really appreciate if you would please complete that before you log off. We're going to use this to continue to use and better the webinars. And then I'll invite Dr. Gaolathe at this point just to say a few closing remarks.
Thank you very much. Thank you, Alexei, for this great update. And before I close, there is a comment on the chat box that this presentation speaks to adults only. But let me just reassure you that we do have a pediatric intensivist, and surely they are in the lineup. And here at Circuit Tumile, as Tommy mentioned, we are embarking on an orientation program for our healthcare providers in the district. This really was prompted by the nature of the cases that we get. And I think these important topics speak to that, in that these patients, by the time you call out there or they present to Circuit Tumile, the management upfront puts them at a greater risk. So by saying that, we are expecting to train about 10 or so at Circuit Tumile every month. And I know the Ministry of Health through the nursing office is working on it. But I think we will also take the liberty to invite you through your institutions, especially our district primary and district hospital, to please submit your training wishes or lists to us. And we are very much amenable to hands-on training, and we can work around the logistics of getting your staff here, accommodation, whilst they're here. And I think we have a common understanding that at a minimum, they need to be here about 2 to 4 weeks. So reach out to Dr. Palai, Dr. Alexei, and to my mailbox for those kind of slots. Not only do we want to train you, actually, we do need your hands out here. And I think the more, the merrier out there in the periphery. So let me close by saying that our next session on Monday is by our own Professor Farai Madzibamoto, and he is going to present on ventilation as regards to COVID. So thank you for joining us today, and we'll all meet you on Monday. Thank you.